Retinopathy of Prematurity, or ROP, is a disorder in how the retinal blood vessels develop in the preterm or low birth weight baby. The retina is a layer of light-sensitive cells that line the back of the eye and is responsible for receiving visual information, converting it into neurosignals, and passing this on to the optic nerve for transmission to the brain. The retina is one of the most metabolically active tissues in the body, and as such requires a very good and continuous oxygen supply, which is delivered by the choroid and the retinal blood vessels. The choroid supplies the outer part of the retina, whereas the retinal blood vessels supply the inner part of the retina. Premature birth can disrupt the normal growth of these retinal blood vessels. If we look at the normal growth of the retinal blood vessels, they start to develop from the centre of the retina at about 16 weeks gestation. They grow gradually in a forward direction around the inner edge of the retina toward the front of the eye. But in order to grow, the vessels require the presence of specific growth factors, namely vascular endothelial growth factor, or VEGF, and insulin-like growth factor, or IGF-1. VEGF is released from specialised cells called astrocytes, which are released into the vitreous humour from the optic nerve. They position themselves in the parts of the retina which are yet to be vascularised, and in this way they guide vessel growth. Astrocytes are able to detect levels of hypoxia in the eye, and therefore release VEGF in response to this hypoxia. It is the relative hypoxic environment that exists in utero that stimulates VEGF expression and therefore makes retinal vessel growth ideal in the fetus. It is important to remember that hypoxia needs to exist in order for VEGF to be secreted and therefore for retinal blood vessels to grow. IGF-1 must also be present for vessel growth. IGF-1 is a growth factor that is supplied to the fetus by the placenta, and it has a permissive function for VEGF. In other words, even if lots of VEGF is present in the eye, vessel growth will only be optimised if IGF-1 is also present. As the retina becomes increasingly vascularised, the astrocytes recognise the increasing oxygen levels in the eye, and therefore VEGF expression decreases. This results in slowed vessel growth as the baby reaches term, with the retina usually fully vascularised between 36 and 40 weeks gestation. In babies born before 31 weeks gestation or weighing 1,500 grams or less, the retinal vasculature will not be fully developed at the time of birth, and subsequent growth of the retinal blood vessels may be abnormal. ROP occurs in two phases. Phase 1 of ROP is caused by the effects of high levels of oxygen on the developing vessels. We know that VEGF secretion and therefore vessel growth is stimulated by hypoxia, but after birth the baby is born into a high oxygen level environment. The astrocytes recognise this, and so VEGF secretion is turned off. The baby has also lost its IGF-1 supply from the placenta, and as a consequence of the loss of these growth factors, retinal blood vessel growth stops. The high levels of oxygen can also be toxic to the existing immature vessels. They can constrict, regress, and spill their contents into the vitreous humour, ultimately causing scarring. Initially, the lack of blood vessels to parts of the retina is unproblematic, because the oxygen supplied by the choroid and the existing vessels is sufficient. But by about 30 to 32 weeks gestation, the retina becomes more metabolically active, and so it starts to demand more oxygen. At this time, the parts of the retina without blood vessels starts to become hypoxic. This is where phase 2 of ROP can develop, often referred to as the ridge formation and vasoproliferation stage. The hypoxia in the part of the retina without blood vessels starts to re-stimulate VEGF secretion to encourage vessel growth, and this is supported by the fact that the liver also starts to produce IGF-1 at about the same time. And for some infants, vessel growth will then develop normally in a forward direction along the retina, but in others ROP will develop. It isn't rocket science to work out that the poorer the vessel growth, the more hypoxia exists, and therefore the greater the VEGF response. Very high VEGF levels combined with the increasing levels of IGF-1, can result in pathological vessel growth. In ROP stage 1, a thin, flat demarcation line can form between the vascularized and avascularized retina, and by stage 2, this demarcation line becomes thicker and higher, eventually forming a ridge-like structure across the vitreous humour. The vast majority of infants identified with having stage 1 or stage 2 ROP will often go on to develop normal vasculature without any treatment, but by stage 3 the need for treatment becomes increasingly likely. In stage 3, the release of VEGF stimulates vessel growth, but the vessel growth is abnormal. Not only are these new vessels immature, fragile and leaky, but they also grow in the wrong direction into the centre of the eye rather than along the edge of the retina, and they can proliferate along the posterior side of the demarcation ridge. Large areas of the retina will remain without a blood supply. ROP stage 4 or 5 are the most severe end of the disease spectrum. The scarring from the abnormal vessel development, the damaged vessels and the demarcation ridge can cause the vitreous humour to contract, distorting its shape and pulling the retina away from the back of the eye. This can result in partial or total retinal detachment and can cause severe and permanent vision loss. In the UK, 60% of infants screened for ROP, that is infants born before 31 weeks gestation or weighing less than 1,500 grams, will develop some degree of ROP. However, only about 4 of these will develop ROP to a severity that requires treatment. Treatment options include anti-VEGF treatment, laser treatment, and surgery.